To join us for the opening ceremony. So come on inside and take your seats. And don't be shy, don't sit at the back. There's enough space, plenty of space in the front, so. We would have loved to wait for everybody to come because there is a traffic jam all over Addis, we know that, but we're gonna have to stick to our program. We've already given extra minutes to wait for everybody else, so. Okay. Ladies and gentlemen, our esteemed society members, affiliate and collaborating organizations, and our honorable guests from near and far. Welcome to the 70th Annual General Meeting and Scientific Conference of Ethiopian Society of Orthopedics and Trauma. This beautiful community has grown exponentially in the past decade, as we can all witness, with 7 large orthopedic training programs throughout the country and over 400 members and still going strong. Our society has undoubtedly marked its presence in the healthcare system of our country with the reputation for hard work. Officially open the AGM and an award ceremony. I would like to welcome Dr. Ephraim. Please put your hands together. Thank you.
Thank you very much. It's really a great pleasure to see you all, every member from every corner of the country. I can see members from Jimma, from Jijiga, Mekelle, and so. So it's really a great pleasure to have you all. So I'm addressing the presidential speech of my dear friend, Dr. Galetao. He is not here as he's with us, as he's grieving with for the loss of his father very recently, so he could not be with us, but he really worked hard to organize this conference with us. So I will directly read his speech, okay? So, thank you all again, all esteemed colleagues, honored guests, and distinguished members of the Orthopedic Society. Professor Narendra Vaidya, Managing Director of Lokmanya Hospital from Pune, India. He was willing to come as keynote speaker for this year, so we really are thankful for your presence, so thank you very much. Please give a round of applause for him. Dr. Claude Martin, as you all know, AO Alliance has been instrumental with us, so, and he is also a keynote speaker for us, so thank you, Claude, and the AO Alliance team for coming. And of course, our beloved family members, like from the Sign team, Jane Diller, as you know, the CEO of the Sign team is with us, and her engineering team, Terry and Frank are also with us for this year. So we are really happy to have you here. So thank you very much for coming and accepting our invitation. So I'll directly read his presidential address. So my esteemed colleagues, honored guests, and distinguished members of the Orthopedic Society, I'm proudly humbled and honored to stand before you today as your president. And as we gather for this annual convocation, I'm reminded of the extraordinary privilege to be part of the esteemed community of these dedicated professionals. Throughout the past year, we have witnessed remarkable advancements in our field, in the field of orthopedics and trauma surgery. From the development of cutting-edge surgical techniques to the integration of innovative technologies, the pace of the progress has been nothing short of breathtaking. As we look to the future, I'm confident that our collective efforts will continue to revolutionize the lives of countless patients, as we have done so far. At the heart of our mission lies a profound commitment to excellence. We strive to provide the highest quality of care to our patients, guided by the principles of innovation, evidence-based practice, and compassionate service. Our relentless pursuit of knowledge and clinical refinement ensures that we remain at the forefront of our field. As we navigate the complexities of the healthcare landscape, it's imperative that we advocate for policies that support and advocate for patients and advances of our profession. We must work collaboratively with policymakers, insurance providers, and other healthcare professionals to ensure access to affordable and equitable orthopedic care of all. Beyond our clinical responsibilities, we have a broader role to play in shaping the future of healthcare. We must mentor and inspire the next generation of orthopedic surgeons, fostering a culture of curiosity, innovation, and compassionate service. We must engage with our communities, educating patients and advocating for health and well-being. Our society has a history of collaboration and partnership. Together, we have overcome countless challenges and achieved significant milestones. As we embark on the next generation, I urge all of us to continue to embrace the spirit of unity and support that has defined our organization. In the coming year, we will work tirelessly to advance clinical research and innovation, enhance patient education and advocacy, and promote diversity and inclusion within our profession, strengthen our relationship with other healthcare stakeholders. As we come together in the pursuit of these goals, I'm confident that we will continue to make a profound impact on the lives of our patients and the broader community. This year's theme, the management of fracture-related infection, is a topic close to our hearts as orthopedic surgeons. And we have a privilege of treating significant number of patients, of course, a bad privilege, right, to treat infection, specifically fractured infection. A significant number of patients with infections related to fractures and trauma, which has only cemented our belief in the need to develop deeper into the topic and shape our experience with our esteemed colleagues and partners. So here we have invited really a very experienced expert on the topic of fracture-related infections. So Dr. Mario from Switzerland, even if he could not make it physically, but he will be presenting online today. At last, I would like to express my sincere gratitude to our esteemed members, executive committees, and the team working to organize our annual meeting. And it is through this, our collective commitment, that our society continues to strive. And please give me the chance to really appreciate the organizing team, the editorial team, and General Assembly organizing team who have really tirelessly working all this the past few months. I don't know how many virtual meetings we have been doing so far, and it has been so hard on them, but they have made it successful. So thank you very much all the teams who have been working behind. Equally, I would like to render my sincere appreciation to our partner companies, most notably AO Alliance, who have been really instrumental in the practice of orthopedics and trauma service in this country for the past 9-10 years, since 2015, I guess, since I was by then for the resident. And ADFATIM, who have been also long before that even. Sign International, who have been here and helping for more than 40 institutions in the country. So they are here, and we are really grateful also for their presence. And then for their unwavering support to the clinical service and educational perspectives of orthopedics across the nation, and also to all pharmaceutical companies who have contributed financially to sponsor this event. As you all know, because of the current financial situation going on all over the world, of course, not only in Ethiopia, but they have really devoted themselves to be part of us. And then now we have 17 sponsors who are part of this event. So I really would like to thank them all. So please give them a round of applause. So let us embrace the challenges and opportunities that lie ahead with the same passion, dedication, and unwavering commitment to excellence that has always characterized the orthopedic society. And together we will build an even brighter future for our profession and for our countless patients who rely really on our care. So thank you very much. So this is his presidential address. So I hope I've done justice to his presidential address. Thank you.
And of course, the only professor in orthopedics in Ethiopia as well. So, yeah. So Professor Brook has been lucky enough to serve his country in multiple ways and really is one of the people that we aspire to become. So, Professor Brook, I would like to give you the stage to give the official opening and welcoming speech to the annual general meeting. Give him a round of applause.
Good morning, everyone, and welcome to Ethiopia. There is a huge international presence as my best ever resident. Always Mnawur and Ephraim compete. Still, I couldn't decide. Sami as well, and Galatau. The list continues. You can't choose. All are the best. He addressed it very well. There is a huge international presence in this special meeting. And the senior staff from the mother department, the neighboring department at St. Paul, military, police, federal hospital, from regional 11 medical schools, we have residency programs running on, and other hospitals where there is big orthopedic practice, females, males, all good orthopedic surgeons of the nation of Ethiopia. Welcome to the 17th AGM of Ethiopian Society of Orthopedics and Traumatology. Please give a big, loud round of applause for yourself. Because these days it is tough to come for meetings, especially our colleagues who came made up from the regions, from 800, from 1,000 kilometers away. Please especially let us thank all of them. I'm not a guest, I'm a host, I suppose, but using the hat Anania endorsed on me, I'm very pleased to give this opening speech. As you know, the government of Ethiopia's government direction is to appraise trauma care. You can see left and right, you can hear left and right. These days, the government is talking about subspecialty mapping, avoiding abroad referrals, reverse medical tourism. These are the words you see on the news, day and night. This is what a time, what a catching moment. We should all sit, talk, and come up with a reasonable plan. In all 13 subspecialties in orthopedics, we have to excel and take care of our people. That's why the committee is wise enough to select and invite the giant stakeholders. All across from the US, CEO Jean, our favorite queen, we call her Queen Jean, with her engineering team. She is here. She has been in Blackline yesterday, all day, operating, teaching, lecturing, coming back with different designs. The engineers will tell you later on. And our honored main speaker of the year, Professor Narendra Vaidya, whom you enjoyed 10 years back in Ethiopia. He was our guest of honor at that time when he was practicing the first robot-assisted total knee and total hip in Pune. That was, I think, the first in India as well. Next year he invited me and I operated with him in that laminar flow theaters, which I always aspire to have it in our country. Some started already. And this professor now is running all the 4 brands, the 4 major types of robotic surgeries. So he is our main guest of honor. So now forget about starting primaries, first knee, here and there, total hips. Now, guys, you should talk about revisions and robotic knees. This is the time. What a time is coming for Ethiopia. What do the residents feel now? And what I felt when I was a resident, should be completely different. Now look, you meet people, you see technology, you plan with engineers, designers, you talk with industry outside, which will soon open and see. This is a time for Ethiopian orthopedics to shine, to rise, and to race fast. The society outside is now, God knows how many we are, but statistically I think we are 130 plus. That's how I know. I know the number of mobile users. Then I know also our society is 50% less than 15 years of age. So if you do some mathematics, no question we are way above 120 million. So these all people outside are waiting us everywhere. They get fractured when they make their breads outside, when they drive, when they work. So trauma is still, especially from traffic injuries, a leading cause of injury in low-income countries that Claude will tell us later on. And then construction, you have seen from the corridor up to high-rising buildings, always there is activity in all regions. This adds to the burden of trauma care, fractures from fall injuries, because the society is aging. Our life expectancy just moved to 65 now. So people fall, people get old, Parkinson, balance issues, cataract, so they are liable for fall. So these all demand and knock your doors. What they saw on YouTube, is it available here? Put it here, put it there, put it there. They ask you. So this is our responsibility, and ESOT's major responsibility to show directions that align with the government's policy and recruit brilliant trainees, educate them, equip them, guide them, lead them, provide them with infrastructure, plus provide them with equipment, with right leadership and guidance. I think the government's motto of avoiding unnecessary abroad referrals will be achieved. And we trust on our students, fellows, residents, nurses, hospital directors, porters, cleaners, all of the team in the OR, in the patient care. They work in concert and they work together and come up with best solution to treat our patients at homeland, to reverse medical tourism, rather make Ethiopia the hub of referrals from nearby countries. We see lots of Eritreans, Somali patients. We see patients from Djibouti. We know most of our graduates are working in those countries as well. And we know we trained residents from these countries and they went back and they are functioning, South Sudan, Somalia, and whatnot. Therefore, it's our big task to have such meetings, chat, network. That's why we opened in the morning. We gave you ample of time so that you can network, you can talk, touch people that you just know on YouTube, on pictures, on Facebook. Claude is there, Jean is there, Narendra is there, big guys inside, and the senior consultant from other departments, Colonel Major Brook, Commissioner Daraja, military leaders, police leaders, surgeons. The heart is also in the surgery. So talk to them, network, chat, and look for further trainings. Always, I push residents to pursue fellowships. With general care, you can't cover everything. The demand is so high. So listen your inside, know your talents, inclination, and pursue and ask advice from big guys, from advisors, mentors, how to link and work. Don't kill your dream. Don't think few special people will do it. You can all do it. If someone did it, you can do it. Therefore, this conference, I expect, will help you to network. We are blessed, just in this society, we have spine surgeons. I have seen Caleb somewhere, Skander, returned back from fellowship. We have surgeons who did sports and returned back, Malasa, Mammo, Mahadar, etc., Muhammad. And gradually, this room is getting, sorted out into subspecialties. Foot and ankle, the others for pediatrics. Some fellowships are available, like trauma we have, and pediatrics soon we'll have with Baharo and Brano and Elsa and Samrai. But the others also will open at private, in rotations, and at government hospitals. Therefore, my advice is to network, look for a mentor, ask advice, ask phone numbers, ask emails, nag them, and seniors, big people, great people, leaders, I kindly, humbly ask you to teach at least 1 or 2 residents. Show them the way, link them to funds, and make access very easy, and coach them, let them go and come back so they can help the society. During this organization, this AGM organization, I've seen them working hard, and especially Mangistu, it's another spine surgeon we have, and Bezawit. I should mention this because Binyam, UL, and Ephraim himself, and Galatao added. And whom do we miss? Just open your list and see the editorial committee. You can see the list there. This is a hard task, but we left it open to the youngsters. My seniors taught me to do this. I've done this 10 times. This is 11's magazine. I've done maybe 3-4 pages. Otherwise, most of this is written and done by the emerging youngsters. And what a pleasant news, what a pleasant sight to look at this. Please thank them on behalf of ESOT. As you see on page 6, our list is growing very much. The summary is at the end of page 6. You can see there are around 352 graduates from all disciplines, and currently there are about 275 residents in different programs. This is distributed downward. Please, donors, exhibitors, leaders, program managers, have a look at this list. This is the hope of Ethiopia. From this 275, we can raise many, many shining specialists. Recently, I just met Tashala Ayana behind, who just came back, and Fasil, and I can mention Milkas, Nawur, Muskara. I mean, lots of subspecialists are coming back. And they didn't disappear, they came back to help the society. What they need is now to equip them with implants, to guide them, and to connect them with the industry. Then this makes the circle complete. Training alone is not enough. They should be equipped, plus they should be followed, resupplied again, and trained again and again. With this, definitely abroad referrals will be stopped, at least the unnecessary ones. This is the direction of government, and with this umbrella of hope, I think we'll be having an excellent conference. The speakers will elaborate more on this, and this is the main team they selected as well. And there is exhibition, big exhibition prepared. Don't hesitate to talk to the industry because we work with them, network with them, and I already conveyed my message. Teach residents, sponsor fellows, then equip them, send them back. They will hear, practice in an excellent way. This is my message. Having said this, I declare the 17th beautiful, full house. Look at you. And we have emerging good number of female orthopedic surgeons, and we encourage that as well. I don't want to forget that. Ananya will kill me. So we have trainees more and more involved. So we encourage and welcome again. And did I forget anything? I think I'm okay. Let's shout, give applause, and open together the 17th AGM. It is officially open. This is for the meeting. Let's applaud also for the exhibition. Thank you very much. Enjoy.
Annual award session. We're going to have 3 awards given this morning, and we're going to have, I think, 3 more at the end of the conference tomorrow. So I would like to invite Professor Brook and EC members, Executive Committee of Ethiopian Society of Orthopedics, to the stage to give the awards. All EC committees, Manawir, Miske, Nardi, where's everybody? Mamo, Sami, አሰላለፋችሁን አስተካክሉ። በቁመት ነው I think መሆን ያለበት Okay. So our first award recipient graduated with a medical degree from Duke University School of Medicine. This marvelous individual has contributed many scientific papers, books, and most importantly, heartwarming stories. He was inspired by the devastating outcome of patients with fractures in Vietnam and conceptualized what we have now come to know as SIGN. ESOT proudly presents this year's ESOT High Merit Award to Dr. Louis Zirkel. Round of applause. In recognition to your outstanding achievements and significant contribution to the field of orthopedics and trauma, our Orthopedic Society and its members greatly appreciate your unparalleled service for humanity, your commitment to the growth of science, clinical and community services. Congratulations. I would like to invite Jin to receive on behalf of Dr. Zirkel. Let's keep it going, come on. If you don't mind, you can wait on the stage so that we can have a group picture at the end. Thank you. The next award recipient is someone who has been a teacher to us all. He is one of the very few individuals who carried the name of orthopedics in Ethiopia before it became what it is now, for exactly 17 years. We all know him for his dedication, excellence in knowledge, and warm personality. Besides, I don't think most of us know, but this person is almost a professional athlete. He runs, he plays soccer. If you go to a dodo on the weekend in the morning before dawn, that's the person you're going to be seeing running. ESOT proudly presents this year's ESOT Long Year Service Award to Dr. Yohayis Falleke in recognition to your outstanding achievement and contribution for long years in service to orthopedics and traumatology. We'd like to thank you for your immense commitment, exemplary clinical service, and active participation in our society. The last award goes to a household name in our country in every training and institution, almost as synonymous with the name orthopedics. Established in 1999 and now with over 150 programs in 44 developing countries and trained more than 2,000 surgeons and treating 60,000 poor fracture patients. ESOT proudly presents this year's ESOT Institutional Award to Sign Fracture Care International. Dr. Jin is already here, so we would like to recognize the essential contribution and multifaceted roles that you've played in advancing orthopedic care and improving lives of many patients in Ethiopia and beyond. Our society and our country deeply appreciates your unwavering and never-ending support from your organization. Congratulations. Okay, I'll give 5 minutes for the awardees to say something to the audience, and then we'll go have a group picture. Jen? Ladies first.
Okay. Hello. Thank you so much for this award. Dr. Zirkle will be highly honored to receive it. He, of course, has lived his whole life to help the surgeons here in this room provide excellent and timely care to their patients, and we carry his torch on as we move on together to improve orthopedic care worldwide. Thank you, too, from all of our staff at Sign Fracture Care International for this other award. It's very meaningful to all of us because you are a part of the Sign family, and I know that Sign is always a part of the Ethiopian family. Thank you. God bless.
Thank you very much. It is not only my achievement, it is the achievement of my teachers, fellow surgeons who worked with me these many years, and also my students also. I want to thank everyone. Thank you.
Okay, Professor Brook, as usual, he has all the information. So he's telling me that Sign has been awarded before, but they never made it to take the awards themselves. So we're very excited that you're here this year. Thank you. So let's take a group picture. And following that, we'll proceed to the official opening of our exhibition outside in the hallway. And we'll have group pictures on the stairs on the right side, which is the stairs you took to come up to this floor. And with our guests along with us. And then which will be followed by a tea break. The tea break is just across the hall, right in front of you, the long rectangular hall. So when you leave, please make sure you give priority for people who are sitting in front, our guests and our teachers, and proceed to exit the room with patience. Thank you. Some housekeeping pointers. Bathrooms are on your left along the hall. And those of you who haven't registered, please complete your registration at the registration table on the right by the stairs. Those of you who have paid your annual membership payment, you can get receipts from that same table. And those of you who haven't, please complete your payments using mobile banking. Thank you. We've worked tirelessly, the editorial committee has worked tirelessly to have this magazine put together, and you're gonna find many articles, all the articles that will be presented the next 2 days. They're in your book, in the magazine, and we have news from all corners of Ethiopia. And we're hoping by next year we're gonna have an Ethiopian orthopedic and trauma clinical audit, basic principles of musculoskeletal trauma, and guide to ATLS, BLS, and SELS. So please connect with him. Where's Dr. Manezo? Is he outside? it would be really nice if we can all see him so that you can connect with him. Find a way to get his books. We need to support each other when surgeons diversify, and this is the best way. Books are the best way to transfer knowledge, right, to the next generation. So maybe later we can introduce him again and connect with him, read his book. Yes, Dr. Manyaza. Yeah, I think that's him. He's coming in. Let's give him a round of applause for his books. Thank you so much for your service to our country, and appreciate that you have transferred your knowledge through your wonderful books. And I want everybody to connect with him, read his books, give him feedback, and make links, okay? Thank you. Okay. Recent advances and current concepts in knee arthroplasty by Dr. Narendra. And I would like to invite upon Professor Brook, Dr. Samuel, and Dr. Fasil to moderate these two sessions to come to the stage. And we'll have a short discussion following the two sessions. So listen attentively, ask questions. This is really an opportunity to learn outside of the OR. All right? Okay, thank you. I would invite Dr. Claude Martin to the stage.
Thank you very much, Anaya. Can you hear me all well? Good morning. The picture that you see on the left-hand side is a picture from Ethiopia. It was one of my first, actually, I think it was my first trip to Ethiopia way back in 2015. And this came to be my donkey lady, because this particular patient, we were making rounds at the Black Lion Hospital, and she'd been assaulted by her donkey, and she put up her forearms like this to protect herself, and the donkey bit both forearms, and she had bilateral open forearm fractures. My name's Dr. Claude Martin. I'm the managing director of the AO Alliance Foundation. I was a trauma and orthopedic surgeon a long, long time ago, trained in Toronto. But let's start off with a short story. So it's mango season somewhere in Africa. Child climbs up the tree, falls down. They go to the health outpost, no x-rays. They try to go to another hospital. The knowledge, the skills and attitude to treat this child are not available. They make it to the road and eventually make it to an area, a hospital, that has the skills, hopefully, to take care of the injury. If the child is lucky, the expertise will be there to avoid complications, avoid disabilities, and also get proper treatment. If the child's unlucky, he or she may end up with a traditional bone setting. They may end up with complications and a lifetime of disability. My argument, and I think the argument that a lot of people that are working with you to take care of your own problems, it shouldn't be about luck, okay? If you read the quote, can you imagine, kid falls out of a tree, goes to a hospital or goes to a healthcare post, and they do not have the expertise to treat that particular child. You've gone a long way in the last 10 years to make an impact in preventing this big issue. Over the course of the next 20 minutes, I'm going to touch upon 4 themes, but I took out the slide about my professional life only to say that I'm working right now on my 9th professional life, so I'm like a cat. Probably, hopefully, this is my last one, and my last gig is that of the AO Alliance Foundation. That's my team, and that's us. We're active in about 35 countries, many of them in sub-Saharan Africa. The name Alliance says we collaborate. So we're collaborating with Jean and Sign Fracture Care International. We're collaborating with the African Doctors for Africa. We're collaborating with ESOT. You can't do it alone. Our budget is about $8 million a year, but if I had more money, I'd be able to spend it. The 4 areas I'm going to touch upon over the next 20 minutes is I want to talk about injuries. Everyone talks about malaria, TB, HIV, AIDS, but no one talks about injuries except you. I also want to talk about some trends in trauma and orthopedics in LMICs. I want to show all the good work that's been done in this country, not just over the last 10 years, but over the last 20 years, And last but not least, I want to go over some of the lessons that I've learned, the humility that I've learned over the last 10 years, because up until January of 2015, I had never been in Africa. I had zero African experience. Now I can say that I've learned a few things. So far, so good? I'm not speaking too quickly? Clear? Good. How many of you drove to the venue this morning? How many of you drove? Raise your hands. You're all staying at the hotel? Now, you guys don't have tendinitis. You're too young. How many of you wore a seatbelt when you're driving? Good. Now, I usually would ask the question, how many of you know someone who's been injured in a car accident? But I won't ask this here because you all know someone, because that's your patients. So if we look at the statistics, and these are WHO statistics, on a yearly basis, all over the world, there's 4.4 million people that die as a result of injuries. Now, 25% of those injuries are related to road traffic accidents. So either you're driving in a car or you're collateral damage from a bicycle, a pedestrian, or whatever. Others are electrocution, industrial accidents, drownings, conflicts, suicide, etc. That's 32% more than the big three communicable diseases. And you know how much money those three communicable diseases get in terms of funding. I'm not going to debate, or I'm not trying to say that those three communicable diseases are not important. They are. But I'm just saying that injuries is forgotten because everyone says that injuries, it's your fault. It's your fault that you're driving drunk or drugged. It's your fault that you're getting 300 people in a bus and traveling. And injuries do not cross borders. One of the big things about AIDS and HIV, way back, is that AIDS and HIV and these communicable diseases, they cross borders. So a lot of money was poured into this. But it's not the deaths that are important for us, for you as trauma and orthopedic surgeons, or anyone that's involved in caring for the injured. What's important is the disability, the people that survive. If you die, you die. You can't do anything. You know, you don't get a chance to practice the skills that you've learned in your residency program. The estimation is that for every death, there's about 10 to 50 people that remain with some type of a disability. And out of those disabilities, about 75% of them are related to your everyday business. So that's a potential worldwide of over 34 million people. And you can say that that's 34 million people in LMICs because 90% of this occurs in low and middle income countries. Let's talk about a few trends that I've seen over the last few years. Some of you may know about NSOPs, National Surgical Obstetrics and Anesthesia Programs, and the Surgical Obstetrics and Anesthesia Workforce. The WHO says that you need to hit 20 of these types of surgeons and anesthesia people per 100,000 population. You heard this morning that Baruch thinks that there's about 120 to 140 million people in this country. And if you look at the color of Ethiopia, it's beige or white. So you're under one. You're a long ways away, but you're not the only one. So but you've come a long way. You know, I remember 10 years ago, there were only 2 residency programs in this country. Now I think there's 10 and about to be 11. So with COSEXA and with ESOT, you've been able to grow the number of trauma and orthopedic surgeons in this country, and as well as in LMICs. Now, the priority diagnosis, a lot has gone into club feet, about 10, 15 years ago. And injuries was there, but was just creeping up. And Dr. Zirkle and the Sign Nail were developing their programs in a lot of the LMIC countries. Now in 2020, injuries is making a little bit of a comeback and becoming more and more important, but you're still seeing the fracture-related infections, the pediatric infections that are quite important. In the future, you're going to see tumors, okay? Especially the osteosarcomas, and we've been traveling. We saw a case yesterday. And then I've seen some other cases where there's a demand for cancer treatment, for bone-related tumors. Your population is aging, but your population is still young. But there's a need for arthroplasty. Sports medicine is also very, very important because your population are getting more and more active. So those are the trends that we're seeing. Now, the training. 10, 15 years ago, there was some COSEXA training. Now the West African College of Surgeons has a trauma and orthopedic faculty, as well as the Ghana College of Physicians and Surgeons is also a trauma and orthopedic faculty. So you're seeing a lot of more people getting involved in training trauma and orthopedic surgeons. You guys and gals here in Ethiopia have a unified curriculum. And as I said, you've got 10 residency programs, so we're seeing a lot more of you to take care, unfortunately, of a growing population. The population in Africa is really the only one that is significantly growing. All of the other populations in Asia, in North America, South America, as well as Europe, are decreasing. You know, down to 1.5 children per women of childbearing age. You know, it's not about the money, but it is about the money, okay? So if you look like a country where I'm from Canada, from a very, very small town in Quebec, and Quebec has socialized medicine, so there's no room for private. We pay 50% income tax, but we have quote-unquote free health care, but it's paid through our income tax. And on the average, the government spends about $4,500 US per patient per year on providing health care. Now, some need more, some need less. If you look like a crazy country like the United States, and the country I live in right now, Switzerland, where the Swiss are hypochondriacs, and the United States is medical legal driven with many, many things, they're spending close to $10,000 per patient per annum on health care. It's not just trauma care, but health care. So if we look at some of the COSEXA countries, well, you're not hitting the mark, and Ethiopia is not hitting the $80 that is currently recommended by the WHO to make an impact. Other numbers to consider is the percentage of the GDP. Okay, now if your GDP is very low, 5 to 10% of the GDP is not going to hit the mark. But you, as a professional society, and as trauma and orthopedic surgeons need to advocate to get a bigger piece of the money, a bigger piece of the pie. Okay, or else it's not going to go anywhere. You're just going to be trending in still water. Aeolans in Ethiopia. Well, lots of good things. Slide from 2015, much younger Dr. Harrison. Dr. Ephraim was still, I think, a senior resident or a fourth-year resident at the time. Bahiru is in the front row. And this is what we call the needs assessment that we did way back then. You see Dr. Graham Forward is there as well. So we locked a whole bunch of people up in a room for about 2 days. And over the course of 2 days came up with some areas of intervention where we thought we could make a difference in trauma and orthopedics in Ethiopia. And those were the areas that we looked at. We looked at education, local capacity building, reverse fellowships. And those of you that have worked with ADFA, they're pretty big on infrastructure. So they do infrastructure quite well. This is a picture of the ADFA patron. I think you all know him. He's a legend in this country. And he's attended one of the courses. I think that picture was from 2017, if I remember well. So we set off on the first country initiative. And in 2015, 2016, it was Addis Ababa centric. So we set out with the Australian Doctors for Africa to educate all first-year residents with the pre-basic course. And that's a picture of the 2016 class where it was still taking place at the Black Lion Hospital back then. And then the regional reference centers came up. So we traveled to Harar, Hosiana, Bahir Dar, Gondar. I've been to all of those places. I visited all those places, and with the partners, with SIGN, with ESOT, and with the Australian Doctors for Africa, I think not me, but you have been able to develop something that works in your environment. And you see all the partners there. It's not an exhaustive list, okay? I ran out of room. Over the last 10 years, I've been fortunate to meet some very, very dedicated and good people that I can honestly call my friends, okay? I put the two big bosses on the top left-hand side, and these are all people that I think have contributed significantly to making what trauma and orthopedics are in this country right now. Along came BOSAD, Bone Setting Against Disability. Big problem with traditional bone setting, not only in this country, but other countries in sub-Saharan Africa. Menge and the Awasa team said, we got to take the stick approach. So they created a database of collecting all of the cases that came to referral institutions that were associated and had a complication related to bone setting treatment. And unfortunately, a lot of the children are affected. Children can't choose who they go see for health care. Okay, it's grandparents, parents, a lot of cultural pressures, and many of them with very simple injuries end up with the traditional bone setters and with significant complications. This has had to stop. I mean, it's very, very sad, and the unfortunate thing is I keep getting x-rays and pictures of kids like this on a weekly basis. And I think BOSAD is trying to make an impact. Now, BOSAD has taken a shift from being the stick approach now to being more of the carrot approach. Some educational material has been developed on preventing childhood injuries. Talks have been going on with the Ethiopian Public Health Association. They've approached the Federal Ministry of Health directorates to try to see about, I think eventually you'll have to regulate traditional bone setters, but that is going to be extremely difficult in a country that, first of all, you don't know how many they are. They're in rural areas. And last but not least, there are some videos that will be produced probably this year. So a lot has been achieved with BOSAD, but as they say, are we there yet? No, we're not there yet, and we got a lot of work to do. We managed to convince our donors to fund a second round of the country initiative. So it started in 2023. And it will last for 4 years, so till the end of 2026. I put the regional reference centers, and I put a big question mark. The conflict and the war has put a dent in what we are able to do and able to help out, so that's why the question mark is there. There's been a big priority identified in subspecialization, and we're still trying to figure out how to facilitate that. The paperwork to do this type of training outside of the country is becoming problematic. And I think the solution is going to be to develop more national fellowships, but to try to convince the Federal Ministry of Health that you don't need 2 years, that you need 1 year is good enough, okay? Some of the infrastructure development will continue. I think ESOT is well on its way to become a true professional association. I think with the support of your membership. Don't forget to pay your dues, quite important, because they can't survive without your dues. And last but not least, I'd love to develop a national Ethiopian trauma and injury plan, working with the government to have an integrated approach of how people that get injured can be walked through the system and get the appropriate care that they deserve at the right time. The other thing that was developed here about a year ago is standards of care. Now, you all know in the United States, the UK, have tried to put in some protocols for the most common diagnoses. And one of them is hip fractures. It became a big problem. When I was a boy training, long time ago, I was talking with Jim. I graduated from medical school 40 years ago, and I've been an orthopedic surgeon since 1990, but I haven't practiced in the last 20 years. Whenever a patient, little old lady, came in with a hip fracture, we try to get her done in the middle of the night because we didn't have any operative time the next day. There was no multidisciplinary team to take care of this patient. As a junior orthopedic resident, you were managing all the medical complications, the diabetes, the renal failures, the dementia, and everything else. And that was not right. So people kind of figured out that this was a big problem, and we needed to standardize patient pathways. We needed to have a standard, acceptable delay for these patients. We needed to have a team take care of some of the medical issues where the orthopedic residents were not good at taking this, to try to optimize patient outcomes. And one of those patient outcomes is the 30-day mortality. With these particular protocols, standards of care guidelines, at least in the UK, where they have a database to be able to do this, and this is where fracture care registries, trauma registries are extremely important, they were able to decrease the 30-day mortality rate by 40%. Now that's a real number. And now they have these auditable standards of care that people should adhere to. We tried to do the same thing. We started with the COSEXA countries. We selected one trauma and orthopedic surgeon who was the leader in that particular country. We invited members from ESOT. We also invited members from WACS and also from Ghana. We locked everyone in a room for 2 days. We polled them about what were the more common diagnoses that were problematic in this country. So we took a lot of shortcuts because normally it takes about 3 to 6 months to develop these, and we did this in 2 days. This is the map and the representation of people that were there. I think Ephraim and Menge were part of the group. Baruch also came by and said hi. And at the end of the day, we chose 3 topics: closed femoral shaft fractures, closed ankle fractures, and last but not least, open tibia shaft fractures, all grades, 1, 2s, and 3s. If you turn to page 36 of your book, of the ESOT book, the guidelines are there. If you turn to page 35, I think you'll see a picture of me from 1996 at the bottom right-hand side. But they're in the book, and they were also distributed in laminated forms. We want you to read them. They've been adapted to LMIC environments. They give you enough latitude to adapt, but we want you to put them in the operating room, in your areas of environment, and we would love for you to adopt them. Bring them to the surgical meetings, the surgical councils at the level of your hospitals. And just some of the few quotes of these auditable steps. They all fit on one page. You know, orthopedic surgeons remember 3 things, and they can read 1 page. So the closed femoral shaft fracture it needs to be fixed with an intramedullary locking nail within 5 days of presentation to the referral institution. It doesn't say what kind of a nail, but we hope you'll choose the signed nail. It doesn't say whether it's closed or open, but it's getting a little harder to do them closed, so you might have to open them. And it doesn't give, it says from the time the patient hits your door, because you don't control a lot of the times the time the patient reaches your hospital. For closed ankle fractures, pretty simple. If it's one of these fractures that has a good chance of being stable and is anatomically reduced, a cast. But you need to follow it, because if it becomes unstable, well, open reduction and tonal fixation. But it doesn't tell you how to do it, because that's your prerogative. The open tibia shaft fractures took into consideration these 3 Bs that a lot of you see, which says that you should not do a primary amputation unless there's been a consultation with 2 senior surgeons, they agree, and you also write something in the medical records to say that 2 surgeons agree to do a primary amputation, and make sure that you're informing the patient as well. Yesterday when we were making rounds in, excuse me, we were making rounds in Jijiga, there was a patient that had a conflict wound around his elbow that wiped out his arteries. And he couldn't come to the fact that he needed an amputation. So right now they've got an external fixator on until the patient can finally decide to have an amputation. But it's culturally very, very difficult, I understand. In there's the WHO surgery checklist that's included. There's some modalities about physical therapy in terms of weight-bearing status. And last but not least, there's DVT prophylaxis recommendations. Real simple. It's not rocket science. And it came about as a consensus. I think the future of improving care for your patients is these protocols. It's not these protocols, but these guidelines. They're not protocols. They are guidelines. Some of them are aspirational. And next month here in Addis, not at this hotel, we'll be tackling the next 3 diagnoses. Hopefully we'll get one of the pediatric diagnoses in these clinical guidelines that we'll develop. So, the do's and the don'ts. I'm still on time. The do's is visit frequently. Go back. You do not do business on the internet, all right? You want to see the whites of the eye. And this is why Jim and I do these, I talk about scouting trips. Initially they were scouting trips, but now they're really scoping trips, where you see what's going on, and this is not to spy on you. This is really to figure out what's going on on the ground, okay? You have to be culturally sensitive, and we do have an ethical duty to first do no harm. You know, this is, it's actually not in the Hippocratic Oath. If you really read the Hippocratic Oath closely, we all think it is, but it's not. But we have an ethical obligation to first do no harm. The don'ts, well, judge. If you look at the picture on the slide, it looks like a really messy plaster room. It is messy, but it's functional. Everything is there. There's plaster. There's a cast saw. There are cast cutters. Yeah, it could do with a little bit of cleaning up, a little bit of organization, but everything there is there, and it works in that environment. I still think that it's not our job, at least AO Alliance's job, to pay or provide what the government should be providing. And that's the basic basket of goods that you need to treat your patients. You know, you need a small fragment set, you need a large fragment set. I think we're very fortunate that Lou and Jean and the Sign Fracture Care International, you know, Lou's been so successful with his nail, but somehow the government has to throw in, but also the patients. I think the patients have to contribute. Surgical safaris, where surgeons from high-income countries come in, operate, and leave behind complications. It has to be coordinated. I'm not saying that I'm against high-income surgeons coming to help out, but they shouldn't be holding the knife, okay? Local people should be holding the knife. So, my take-home messages. Musculoskeletal injuries are a big, big problem, not just in your country, but in a lot of sub-Saharan African countries. We're active in about 26, 27, 28 of them. Not as much as Ethiopia. Ethiopia is a favorite child of ours, along with 5 other countries. But as you saw in the first part of the presentation about injuries, it's a big problem. But people don't know about it. Or if they do know about it, they've got other issues with mother-child, safe C-sections, cardiovascular disease, diabetes, cancer, and the communicable diseases. There's 3 categories of diseases. There's the communicable diseases or infectious diseases. There's the non-communicable diseases, so things like diabetes, hypertension, cardiac disease, renal disease, cancers. Injuries used to live in the non-communicable diseases, but now they've tried to take it out. I'm not sure if that's good or bad, but it stands as a standalone category. You saw it's 10 to 50 for every patient that lives, and that's a significant number of patients where you can really make a difference. And you saw that as most of the disabilities, 75% of them affect the extremities, or musculoskeletal. But it's about you taking care of your own problems. It's about us as international organizations to help you sort out those problems. So, back to my story. Child was lucky because the surgeon, the child ended up with a well-trained trauma and orthopedic surgeon, not a pediatric orthopedic surgeon, but a well-trained trauma and orthopedic surgeon who knew what to do, and you've got a perfect-looking x-ray with all of the anatomical lines defined. Thank you very much for your attention, and I hope that the rest of the meeting is worthwhile for you. Thank you.
Thank you so much, Dr. Klaus, in Pune, India. He is quite famous for his contribution to replacement surgeries. He's done over 6,000 robotic total knee replacements so far, and he has contributed not just to replacement surgery, but spine and trauma in his setting. So let's give him a round of applause and welcome him to the stage.
Good morning, friends. Greetings from India. It is my 4th or 5th time visit in Ethiopia. I was here about maybe 10 years back for your ESOT meeting, where I had given a talk on trauma care. That time I used to do a lot of accident care. And basically it was on the golden hour presentation, the first hour management. And in some difficult situations, we have to, instead of golden hour, like in your country when the patient travels from periphery, it was a silver day concept which I had developed. And it was a pre-hospital trauma care, which was the topic that time. Thank you. I am extremely thankful to Dr. Ephraim and Dr. Biruk for having me here. And can we see the slide here? Yeah, please. So, greetings from India again, and this is my beautiful city of Pune. It is just south of Mumbai, about 100 kilometers south of Mumbai, Bombay. And it's a historic city. It was a cultural capital of state of Maharashtra, which is the 2nd largest state in India, and very highly populated, as you all know. My city's population is huge, and it is probably 3 times of Addis. So, and it's a very well-known, it is called as a Oxford of East, and we have a lot of institutes where we have a lot of Ethiopian students also who are studying in Pune, and We have all types of engineering, medicine colleges. We have 5 medical schools in the city. So it's a very advanced thing. And from KG to PG, as we call it, you have a lot of institutes in Pune. These are my hospitals. I started practicing orthopedics in 1993. Graduated from BZ Medical College, went to US and Sweden and other countries, got my education done in trauma, spine, as well as joint replacement surgery. And now, principally, I am now looking after joint replacement. We have orthopedic focused hospital, which is a teaching institute for postgraduates, as well as a lot of domestic and overseas fellowships. So I'll be giving numbers to you all, where any interested person can apply for fellowship. Of course, my brother, Dr. Biruk, is here, and he will help you to reach us. So these are my disclosures. So now going to the topic, total knee replacement now over last 4 decades has been 4-5 decades. It has been an extremely successful procedure, and it is practiced widely now. When I was started practicing, it was very rare in India also, but now it is a very high volumes, we are doing it. And I'm sure that in coming years, a lot of patients will come to you for knee replacement surgeries in Ethiopia. Even if today number may be less, but it is going to increase day by day, and there are a lot of advances. And it's really a life-changing surgery, and it is very successful. Arthroplasty has not remained only in total knee replacement. We have now patellofemoral replacement. We have partial replacements of medial or lateral compartments. We have 2 compartment replacements, or we have total knee replacement. So all these surgeries are being done. But even if we have been having saying so, still about 20% patients are not extremely happy. They may be painless, they may be walking well, but still when it comes to happiness, they say that no, I'm not happy. So there are certain reasons for that, and that I'm going to cover, and why technology is important, that I'm going to cover in today's lecture. So when we say advances in arthroplasty, there are 3 T's, what I say. The tools, what we do, say in 80s or 90s, whatever instrumentations, what we were getting were not exactly precise. There were, very crude instrumentation, lot of instrument trays. That has improved over last 2-3 decades, and we are getting good designs. We are getting good implants, we are getting good materials. Even now in your city also, in your country also, there are various distributors, same distributors, which are giving us this Merrill and all those people. They are supplying in high volumes in India. Even I am using their implants. Techniques have evolved, minimally invasive surgeries, the CRs, their express knee protocol, which I developed, then unicompartmental. Technology, navigation, ortho-align, robotics, they are all playing their role. So basically, they are all contributing to the improvement in outcome. When we say outcome improvement, there are 2 variables, 2 factors which are primarily important apart from surgical skill. That is the accuracy of implantation and implant design. Implant design has very less impact on the ultimate outcome, but it is, and the manufacturing processes, materials, we have various materials also, but implant accuracy is the most important determinant for patient outcome. So we have various designs like the PS design, which is commonly used. The cruciate retaining designs are there. We have rotating platforms there. We have this journey BCS design, where there is a differential cut of the femoral condyles, and so you have an oblique joint like a natural knee joint, which is in 2 to 3 degrees of varus. So you get all these kind of designs which are available, and I'm sure as the numbers in your country also go on increasing, you will be having access to all these newer implants. Then you have partial replacement, bicruciate retaining implants. So there are various implants which are at the disposal of surgeon. Fortunately in India, due to the high volumes what we are doing now, all the designs, whatever available in Western world, they are all available with us. There are various materials also. We are all used to cobalt, chromium, titanium implants, but now you get this so-called gold implant, which is also, I think, available in Ethiopia also now. Merrill has that implant, which is a titanium niobium nitride coated implant, which is a non-allergic implant. It doesn't, even in metal allergy patients, you can use it. Recently, we did the ceramic total knee replacement in India. It was the first in India in my hospital. We did this ceramic knee. We have oxenium, which is a coated implant again from Smith & Nephew. So you get all these types of implants. So this is just a video showing implantation of this gold implant. So you have this coating here. Even the backside also has coating. It has pockets for cement fixation. It has got studs also. And this is a tibial component, which is a fixed bearing design. You have got keel, which is actually a rough finish, which can have very nice hold in the bone. So these are advanced implants, what I think will be available with your surgeons also very soon. It must be, already made available by the concerned company. And then you fix it. Now come to the basic thing, that accuracy of implantation. Ideal mechanical axis is very important. Unless you reconstruct the mechanical axis, the patient is not going to get deformity correction. Neither the patient is going to get completely painless. And thirdly, there is going to be unreasonable wear of the poly implant. And that's why your mechanical axis has to be completely, absolutely perfect. Accuracy of implantation depends on many factors, like the patient's anatomy. Sometimes in India, we get very short patients, say 4 feet 8 inches, 4 feet 10 inches. Their thighs are big, the range of movement is restricted. In such patients, the accuracy of implantation may be very difficult, like shown in that photograph. Soft tissue releases, balancing, it is completely surgeon dependent in the traditional or conventional knee replacement. So these are all, going to ultimately affect the accuracy of implantation. There are many variables. In the femoral side, the center of femoral head, the flexion extension of the femoral component, distal femoral cuts, rotation of the femoral component, varus and valgus arrangement and alignment of the femoral component. So any step of any of these variables you go wrong, there are chances that our ultimate axis of mechanical axis is not going to be achieved. There is a study which is published in the Journal of Arthroplasty that if you err by 1 millimeter of entry point, then there may be 2 degrees of deformity, and that's a narrow margin where a conventional knee replacement is being done. Hardly 1 millimeter will give you 2 degrees of deformity. So if you have that 1 degree on femur, 1 degree on tibia, the combined deformity can be really huge, which will be which is called as an outlier. On tibia, these are the variables like resection level. Sometimes you can increase, take more bone. If you take less bone out from the tibial cut, the knee will be tight. There will be flexion deformity. Varus valgus alignment may go wrong. So there are many variables, and that's why there may be, ultimate outcome will not be optimum. There are bone cutting errors. We use the saws. The saw can skive off the sclerotic bone. It can go in the osteoporotic bone. And so there may be, again, even if your jig placement was perfect, your cut ultimately will be actually having a deviation from your normal, whatever desired cut it would have been. And there are many instrumentations. Any one instrument you go wrong, then you are going to have outlier. This interesting study in Orthopedic Proceeding Journal, you see that even in high volume cases, experienced surgeon, the outlier means that whatever alignment you wanted to have, there is a deviation from that alignment by more than 3 degrees. So 30%, that every one case after in your 4 cases is going to go wrong. So that is the sort of statistics why there was a need felt to develop technology in the field of arthroplasty. And if you get it wrong, then this is a disaster. Patient will have a lot of problems. Revision surgeries are difficult. They are time consuming. They are very costly. And so ultimately our aim, if you are offering a surgery of knee replacement, it has to be absolutely perfect. Another thing is that TKR is not about just cutting bone. It is a soft tissue surgery. So we tell our residents, fellows that do an adequate soft tissue release. So what is this adequate? Adequate may be different for Dr. Biruk. It may be different for me. So it is all very subjective. So there was a need felt by arthroplasty surgeons that some objective tool has to be there. So we have to take help of science. Surgical techniques has to improve. There are different concepts of balancing the knee, like the mechanical alignment, kinematic alignment. Concepts are changing. Everybody's knee is different. So there is a classification called as CPAC classification. And it has divided classified the knee joints, normal knee joints into 9 phenotypes. CPAC 1 to CPAC 9. And everybody's knee joint is different. And we all used to, in previous conventional technique, put the joint in exactly the same way for each and every patient, irrespective of their phenotypes. So if a person had an oblique joint line, we were giving him a straight joint line, a completely horizontal joint line. And that's why the unsatisfied patients of 20% unsatisfied rate was there. So now, about 2 decades back, computer-assisted navigation was started. It was the first step towards technology. So it is a navigation which will help the surgeon to get your alignments right on the operation table, but it has certain drawbacks. Navigation is like a diagnostic tool. It stands in your operation table, tells the surgeon that this is the level of cutting or this is the release, what you are doing. You can measure it, but ultimately surgeon has to fall back to his skill and then again implement the surgery with a traditional way. So again, the errors were not reduced to a great extent, even if you have a navigation system. So then, what if you have a system which helps us in getting alignment in all three planes? It gives a kinematic alignment balancing. That means the knee is balanced throughout the range of movement, not like only 90 degrees and extension. It is completely balanced in all three planes, all over the range of movement. It allows objective analysis of ligaments, like there is a number which comes in this, and that is where robotic surgery comes in picture. So what is a robot? Robot is a machine, especially one programmable by computer, capable of carrying out complex series of actions automatically. So now here the robot will help us in getting the deformity analysis also. Number two is that you can actually virtually do the surgery on the computer before you actually start cutting. And then lastly, you can then implement your plan with a robotic handpiece or robotic tools. So this is the advantage of robot. So I'm going to show certain videos of different robotic systems. Incidentally, we have all the robotic systems at Lokmanya Hospital in Pune, and my fellows are trained on all robotic systems. So it can be humanoid, which is not surgical robot, and surgical robots are non-humanoid robots. So it's a long history, and currently, you have robots which are active, which can be passive or semi-active. Semi-active robots are the ones which are very commonly used all over the globe, and this is where the surgeon is always in command. Active robot means surgeon plans and he stands out, and the robot will carry out all the bone cutting. So these are some systems in the market which are active systems. Personally, I am not very much aligned to that. I need to be involved in the surgery entire time. My hand feel and judgment are very important. I cannot give the surgery to robot. So I don't encourage the active robotic system. I always use all the systems, like all these semi-active or semi-automated systems are being used. And the market is going to be flooded with robotic systems in the coming decade. You see 159 robots are pending FDA approval, and these robots are being developed. So all of us, and ultimately once there is a competition, more and more numbers are being used, the cost also is going to go down. So we have to get trained and we have to look at the future, and I urge that some of you who are interested, come to our center, learn about robotics. It may not be immediately available, but I don't see that it will take a lot of time to get technology in your country here. So this is how it works. Now first is the mapping. Now here, to understand the bone, we just move the probe over the bone, and it creates a virtual three-dimensional image of the bone on the computer. So there is nothing left to imagination. It will create the exact bone model on the computer, and that will show that what is the anatomy, what is the morphology of that particular knee joint, what we are practicing. So I'm just moving this on the distal end of the femur, and you can see a nice virtual model being created by the robot. So this is the first step in robotic surgery. That is called as mapping. So you rotate it wherever you are mapping, that surface will get automatically rotated, and you will have a beautiful model which is there in this. So this will analyze the deformities, this will analyze the size of the implant, this will analyze the rotation, whatever variables in TKR, whatever I mentioned in some earlier slide, everything is told to us by just mapping of the bone. So it's a fantastic technology, and the same thing is done on the tibial side, and you have mapping of the tibia also. So once femoral is done, you can see that that blue line which is there, that is, it's slightly faint there, but the blue transverse axis is a transepicondylar axis. So epicondyles are, a region. When we did a traditional knee replacement, that could go wrong. And that is where here it is giving us the points, epicondyles, that is being mapped. And the same thing is done on the tibial side. You have to just move the probe on the top of the tibia, on the tibial condyles, and you will get actual exact morphology of the bone. So any child also can do it. So it doesn't, it gives you consistent, reproducible results. It is not depending on whether, what is the mood of the surgeon, whether he was happy, whether he was tired, nothing. It will get absolutely, whether the surgeon was junior or a senior, it uniformly gives the same results and takes out all the variables from the surgery. So this is called as mapping. So this is done in different ways in different robotic systems. So now I'll go to what robotic systems are available. So this is the first generation robot, Mako from Stryker. It was a first generation robot where a CT scan was required of the entire limb. Now the recent, these were image-based robotic systems, and they were very bulky. They used to take a huge space in the operation theater, so you had to get accustomed to that arrangement in the operation theater. So there were a lot of downsides to that. This almost about more than a decade and a half, this Mako is there in the surgical market. Second generation robotics is what I showed just now. That was image free, so you don't require a CT scan for that. It is done with a handheld robotic system. It is very convenient. You don't have to, it doesn't occupy any space in the operation theater, and you have to just do carving. It is, we call it sculpting. So you don't have to use a saw also in this. The burr is there. That burr will take off the necessary bone and it will just cut the bone. So this is the handpiece with which you do the surgery. It is like an arthroscope. So it's very convenient. Then we have this another system, which is the third generation, that is ROSA system from Zimmer, where it actually doesn't use any cutting instrument. It will keep the jigs and it will move the intelligent arm, which will place on the jig placement principle. And the fourth generation Velis is from Johnson & Johnson, where you have a table-mounted robotic arm, which will be carrying out various difficult tasks in the surgery. And a QS is a completely automated robot from the Merrill. So there are advantages of robotics, that it is a three-dimensional assessment of deformity. It gives you whatever alignment philosophy you believe in, you can get it. Completely all the cuts are done by the robotics, all the variables are taken care of. So all these drawbacks are taken off. So there are alignments, so I am taking the tibia forward, adjusting the slope, exactly the joint line is restored to normal. So nothing left to imagination. Completely, it is a perfect surgery every time we do it. And then you know the axis of movement also. Then you can distalize or proximalize the femur. You know where is the point of contact. That is, dots are point of contact. So you again reconfirm that your trackers have not moved. And then you cut this bone with a burr. So you get this virtual image where red is 3 millimeters, blue is 2 millimeters, green is 1 millimeter. And with the burr, you just carve out or sculpture the bone. You don't have to use saw. You don't have to use any other instruments. Only one burring instrument is enough. Make holes for the implant, studs. After that, we go on the tibia. I do this tunneling technique. It takes hardly 2 minutes for femur and 2 minutes for tibia. Average time taken for the surgery for total knee replacement has gone down with robotics now. Initially, there is a learning phase, but once you learn and adapt to the skills, the surgery is done hardly in 17 or 18 minutes. I have published a paper on that operative time. Then you take a trial, see the movements, again you get a chance. If it is not optimum, you can again go back, change in the planning, and again do some burring or sculpting. And then cement the components and put it in place. So in this particular case, we are using an oxenium implant, that is oxidized zirconium, which has got a very good wear properties. It has got almost 30 years in survivorship data. And you can see the time of surgery goes down to almost 16-18 minutes now. And every time it is a consistent preparation, you don't have any variables, and you get consistency in implantation also. So any number of cases you do, every time the X-ray is going to look alike. So there are, now we have completed recently 16,000 robotic surgeries in last 7-8 years, and that is one of the highest in the world. So you can see that UK is going to increase, and there are certain publications which is saying that robotic surgery is going to be the way forward for the partial replacement. So now I'm going to show you the total knee replacement videos, where again we'll go through all the steps, where initially it is it's mapping. Mapping is done like we saw in the earlier video. Every time it is the same consistent sort of a workflow, which is helping surgeon to understand the deformity, understand the bone defects to perfection. Once we do this mapping on the femoral side, we go on the tibial side and then analyze the overall deformity. I'll just fast forward this. Then the tibia is mapped. After mapping, you get all this virtual bone removal with a burr. You just carve out the distal. You can see the burr in action. So just take out some millimeters of bone. So it's very precise. There is no bone loss. There is hardly any ligament release is required. So it becomes a very objective surgery and very precise surgery. So just burring of the bone is done, and that takes care of the complete shaping. Now this is a video of Rosa's figures, so how much is the varus, how much is the gap, so there is nothing again left to imagination. You adjust your prosthesis in proper place and then you cut the bone. So this is the tibial cut now, this is a saw-based system and you don't have to, there is nothing, no jigs, nothing is used. This is one particular intelligent handpiece will carry out entire tasks for you. So all these messy trays are replaced with just one stand and one robotic arm. Then you put this tensioner to understand the tensions in the contractures of the ligaments and take the knee through the range of movement. So you get all these graphs and you understand this, and you can have a balancing screen like this. You can see on the right hand side, on the left hand side, you can see that the joint is absolutely sub-millimeter accuracy. It is completely balanced. You can see 10.5, 10.5, 10. So within 1 millimeter balancing is there. So that's the accuracy which robot brings in picture. Once we do this, then we go to the femoral cuts, because that is one more chance. If there is something wrong in the graph, you can still adjust on the femoral side and get your things right. So this is how the femur is prepared, again with the saw. No jigs are required. You can reconfirm the cut with this probe. That will show that your cut is absolutely perfect. So this is how all the 4 cuts are being taken. And it is absolutely optimum accuracy is there, and very convenience. You can see the assistants are not required, with self-retaining retractors, everything is absolutely very smooth. And then finally you get this graph, and this is how the picture is there. So let's go through some of the review of literature. There are many papers now which have come up. Robots are in place now, almost 1.5 decades we are there. So this is a study where CT-based analysis was done, and it showed more accuracy in robotic surgery. Advantages of robotic TKR is again showing, this paper also showing greater component accuracy. This paper shows that the outliers were 20% in conventional surgery, whereas with robotic it had come down to 3%. In this paper again it shows some similar results. There were no outliers with robotic surgery, so whatever you planned, you get whatever you planned. The implementation and execution was absolutely perfect. So this is how robotics has brought in a great sort of accuracy in the surgery. The recovery time, because your soft tissue releases are very minimal or not there, just bone implant placement varies. There is less bleeding, there is less sort of hospital stay and early discharge, less pain. So there are a lot of advantages of robotic surgery. There are 10-year follow-up studies also showing better results for robotic surgery. So there are a lot of, in literature, there are a lot of papers. This was our paper, which was done for high-risk patients like CABG patients. In conventional, you had to put the intramedullary rod, and that gave chances of fat embolism syndrome, which is now completely taken off. You don't have chances of fat embolism here, because we are not putting anything intramedullary. We again published a paper in the Journal of Arthroplasty where joint line restoration was absolutely perfect with robotic surgery, and that is how it has the patient satisfaction is great. There is no patella alta or patella baja in these situations. So the robotics is here going to stay, and it is going to be there in practice, and I'm very sure they are going to be in your country very soon. Let's see some of the patients. Bilateral rheumatoid arthritis patient walking with a limp, three weeks post-operatively, completely gait has improved. This is how independently she can climb the steps also. Another patient with very great 30-degree varus deformity, completely, with fixed flexion deformity. About 6 weeks post-operatively, walking without any stick or walker. Deformity is completely corrected. Steps also, he can start going. Our protocol is that we make the patient walk next day. In about 10 days time, the stick or walker goes, and we do bilateral single sitting TKRs. Both the knees are done at the same time. And after that, the patient goes on the steps on 3rd day and is discharged on the 3rd or 4th day. The patient can drive vehicles also within a matter of 2 months. Another patient with very gross deformity with waddling type of gait. He has got 20-30 degrees of flexion deformity, very bad rigid varus. About 2 months post-operatively, he is absolutely independent. Another case, very bad case. You can see that the stiffness of the leg. Patient is crippled, rheumatoid arthritis patient, bilateral TKR. This is 2 months post-operatively. Walker has gone, her quality of life has improved tremendously. So this is how, the quality of life actually improves after knee replacement. Another patient with a bad valgus deformity, she is even unable to walk also. Her deformities were corrected, and now she can actually go to even sports activities. She is doing this, spinning and bicycling also. So that is the joy of motion which is given to the person. I always tell my residents that, movement is life, life is movement. If your movement is gone from life, then it is actually going to be very difficult. So there are enormous, number of patients. So many patients are there who are, like crippled like this. And in India also there were a lot of misconceptions about knee replacement. But the more successful patients, the more they bring other patients. And that is how the practice goes on increasing. And now we get so many international patients. I have even operated many patients from your country also, from Middle East, Bangladesh. And this is the patient without now walker is gone in 1 month post-operatively. And patients actually can dance also. So this is the joy of motion. This is a patient where she has to use, this is 2 sticks. You can see the instability in the left leg. Anytime it can subluxate or dislocate and get fractured. Same patient 2 months after post-operatively, no walker, no stick, walks normally. You have to actually tell that we did surgery in this patient. That is the fantastic result what we get. This was a retired military officer. Due to his heavy, hectic life, his knees were degenerated and he started getting waddling. We corrected his knees, and I think he can be again fit to go back to military. See the way he's walking. So that is how, there's a fantastic, and this is not a surgery for only rich people. We have a lot of poverty in India, and we offer them very good packages, and we have some schemes also where we offer to all the patients. There are so many farmers in India. India has got a lot of villages and farming this thing. They need to sit down and they need to do this. So this next slide, I am not going to talk much. This lady I operated about 10 years back. She is, able to sit cross-legged. It is very important in Indian culture that they are able to sit down. The earlier technology was not permitting us to, patients to do that. And this is not only that. She was a burden to her family because of her disability. And now she goes to the farm. She always, see the terrain she is walking. So all the ligaments are preserved. So the proprioception also is great. The position sense is great. So patient is very happy. That is the thing. See the surface on which she is walking without any walking aid. Even the younger people are falling behind. This is how she is walking. She is squatting down, she is doing farming work. So that is, she has gone back as an earning member of the family now, from a burden to the family. So all sorts of activities these people are doing. And they are happy in life because people, they don't take them as a burden, and they do all sorts of farming work. And so it's offered to everybody. She is not from a very affluent family, but at Lokmanya, as I told, we help them financially also wherever it is required. And this is the most difficult task, to come down this steep slope. Even for us also it is very difficult. But this champion lady is able to do that without any support, and she is almost running down the slope. So that is the great proprioception. So really patients do wonderfully well if they are motivated. And that's why, we are offering I discussed with my friend and my brother, Dr. Biruk. You can note down the numbers also. Preeti is here and Shreya is also here. People who are interested, we'll be very glad to offer fellowship not only in joint replacement, but in spine surgery and trauma surgery and arthroscopy sports medicine. So you can contact us, and definitely we'll be offering them fellowship. Thank you very much.